Very helpful. We are now going to move on to Alisa Solberg, who is the director of the Point Defiance AIDS projects in Tacoma, Washington. Take it away, Alisa. Oh, wait. Oh, sorry. We might have Alisa muted. Sorry, Alisa. That's our fault. Okay, Alisa, sorry, we unmuted you. Sorry about that.
Oh, no problem. Hi, I'm Alisa Solberg, and Daniel, thank you so much for putting just incredible words to a lot of the experiences that we're having here in Washington State as well. So I'll be talking about the ways that our needle exchange program is navigating healthcare reform in Washington State. And basically, we're flying by the seat of our pants, but it seems that so is the rest of the state, so we're in good company. Just briefly, before I start, there are new numbers out of the Washington Health Benefits Exchange. They're reporting today that we've enrolled across the state more than 55,000 people since October 1st. 31,000 of those are Medicaid enrollees, and 14,000 of those are children. And we're really encouraged by these numbers. I mean, regardless of the bad press and the political spin that's out there. We're also encouraged by the many changes that the Health Benefits Exchange is making to ease enrollment here. We're hoping that by the end of December, many of the bugs will be worked out of the online format and that there will be greater capacity in the call center to meet the incredible demand. So right now what we've heard is that there are about 12,000 calls coming into the call center a day, and they have the capacity to meet the need of about 4,000 of those calls. So it's a really pretty incredible demand. So next slide, please. So the primary source, a little bit of background before I start. The primary source of funding for syringe exchange in Washington State has been state HIV prevention funding. And over the last few years or so, that funding has declined because, as Daniel mentioned, there have been reductions in HIV rates among injectors. So funding for syringe exchange program has been prioritized at a lower level. We also noticed about in the last year that the state was looking for ways to save money by recouping funding for services provided by the ACA or would be provided by the ACA. So breast, cervical, and colon cancer screening, AIDS meds, and other prevention services that syringe exchange fits into were being looked at critically as a source of funds savings. And so the writing was really on the wall about a year ago for us. Also, the other things that were happening was that it was clear to us that the Washington Health Benefits Exchange was going to go through no matter what here. The state was committed to it. Even before the Supreme Court decision came down, there was a huge structure created and processes being put into place. So we knew that they were going to go through with this. Another indicator was that there were HIV service provider networks forming. So the 5 largest AIDS service organizations in the state formed a collaborative and began to approach healthcare insurers directly to provide disease case management. So we saw the writing on the wall, and we started to wonder where we fit into the reform landscape. Next slide, please. So a contact in public health. We have a long relationship with our local and state health department here, which has served us very well. And so a contact at the public health department suggested that I look into the community transformation grant, which the state of Washington had received. So the CTG grant is a federal grant connected with the Affordable Care Act, and 50% of the states, so half of the states, are currently implementing the CTG grant. And in my last slide there of the presentation, there's a link to a list of states that are implementing the grant so that you can see if this applies to your state. So the purpose of the Community Transformation Grant is to address chronic disease and to narrow health gaps across population groups, so to reduce health disparities. And in Washington State, our Community Transformation Grant is focusing on a couple of things. So we're focused on supporting community health workers, the agencies that employ community health workers, because community health workers have been shown for years and years and years now, to reduce health disparities and costs, healthcare costs, and to improve healthcare outcomes. So to do much of what Daniel talked about, that really fit the harm reduction model of our community outreach workers. And unfortunately, here in Pierce County, the focus of the Community Transformation Grant right now is hypertension and stroke, reducing hypertension and stroke. So our local initiative is focused on those diseases, but it's clear that the administrators of the grant will eventually use this model to address hepatitis C and HIV. So what we found is that going to the Community Transformation Grant meetings is an investment in our future, because we can be part of the conversations that will put harm reduction and needle exchange, syringe exchange, on the radar of these administrators as they begin to address other chronic diseases such as HIV and hepatitis C. Next slide, please. Whew. Just have to take a deep breath. So somewhere along the line, over the course of the last year, I had a conversation with one of the administrators of the Community Transformation Grant, who's a bigwig at public health, and he said something that really stuck with me. He said that we're like ships that pass in the night, that syringe exchange and harm reduction use the same outreach model, we create the same outcomes, and we have what Daniel already talked about, we have that access. We have already prepared, already established access to vulnerable groups of people. And but we talk in different terms. And so we're essentially invisible. Harm reduction and syringe exchange is essentially invisible to the healthcare networks. So he challenged me to translate harm reduction concepts into public health terms. And I was going to many, many meetings and listening and learning, but I became frustrated with the amount of time that I was spending. So that cost-benefit analysis. I was sitting in these meetings wondering if anything that I was learning was going to eventually pan out, or if I was going to be able to have input. And then two things happened. I happened into a meeting where they were discussing the definition of, our local definition of what a community health worker is. And I was able to be involved in developing that definition, which I knew was going to eventually be used in funding criteria for future grant opportunities. The other really wonderful moment was being able to participate in an inventory of community-based organizations that are employing community health workers. And everybody in all these meetings, by the way, they recognize us. They recognize that we do what they value, that we are already doing what they've decided will reduce their costs and improve their health outcomes for their people. So this inventory was being prepared by the University of Washington student nurses, and what they've come up with is a really descriptive document of the agencies, local agencies, that provide this service, and it will be used in the future to create awareness among the CEOs of healthcare providers and insurance providers for future funding criteria. So next slide, please. Okay, so we also received information about the IPA Sister Services Grant through Community Transformation Grant meetings. So just being present in those meetings, I became aware that the grant was available. And for those of you, just for clarification, I know that in some states and at the federal level, these are called navigator services rather than IPA services, but they're all essentially the same. We had a very tough decision to make, and Daniel did a great job talking about this earlier. We knew some specifics in our own state. We knew that Washington State didn't have enough healthcare providers in the state to meet the increased demand, just period. We didn't have enough providers. Because the people that we serve have such high barriers and experience such discrimination, we wondered if there would be people who would be providing appropriate care for injectors. And we didn't know if we would be able to find medical homes for our participants. But the grant described a mechanism by which we could provide feedback about the providers to the lead agency. So in our case, our lead agency is the Tacoma Pierce County Health Department. And we saw this as a real opportunity to improve health care for injectors in our state. And so we decided to do it. And really, it's like a leap of faith. Like Daniel said, we don't know if the cost benefit, if any of this will pan out for us. But I think that we all believe, and we made this decision as a staff and as a board, as a group of people with feedback from our participants. And we had really serious discussions here. And so we decided to sort of take that leap of faith. The grant process was just incredibly fast-moving. I think it was really a case of being in the right place at the right time. We had about 3 weeks. We knew that the grant would become available, and they were telling us that, but we didn't have the RFP. So we knew for about 3 weeks, and then they released the RFP, and the RFP or the proposal was due a week later. And within 3 days of that, we had been notified that we received the grant. I've never seen a governmental agency move that fast in my life. It was a little stunning. So next slide, please. Oh, there we go. Okay. Since we received the grant, many changes have occurred out of the health benefits exchange, sometimes daily changes. It's been kind of a whirlwind. Not kind of, it's been an extreme whirlwind. And we've been discovering ways to build the plane. I don't know if I actually even talked about that analogy, but all along, the administrators, the people at the Health Benefits Exchange, all the way down to the health department, have talked about the fact that we're building this plane in mid-flight. And it's a really good analogy, and it's scary as hell, and all of those things. But what we've learned since we started assisting people with enrollment is how to build the plane to our own advantage. So here are a couple of ways that we've done that. The official advertisements out of the Health Benefits Exchange are not culturally sensitive, not just for us, but for pretty much all of the other IPA agencies, local agencies. And originally they told us that we could only use their advertisement and that we couldn't create our own. But they've reversed that, and so we were able to create a flyer with participant feedback highlighting the benefits that are relevant to the people that we serve. So Suboxone, methadone, drug treatment, dental, and wound care. We also have discovered that Medicaid is easier to qualify for than at ACA. Originally it was intended that that enrollment happened entirely online, but with the high volume of interest and the error rate, there's also a high error rate with the online format, the Health Benefits Exchange decided to begin accepting paper applications, which has really been a benefit to our and fits really well with our outreach model. So we do about half of our syringe exchange volume through secondary exchange or primary exchange, and the paper application we could distribute, and it could go out to people through secondary exchange, through the primary exchanges, to people that we might never see. And we took the Health Benefits Exchange 14-page application and we cut it down to half a page. And we've been distributing that through our secondary exchange, through our mobile exchange. And the real benefit of that is that people can be prepared when they call in, or they can send their paper application back through our outreach workers to our in-person assisters, who can then reach out to that person. Our primary concern has always been honoring the trust and skepticism of our participants. So because they have such high barriers and meet with such discrimination, we knew all along that we couldn't simply enroll people. that we had to help find appropriate providers, or appropriate medical homes. And so our grant right now is just, it's a small grant, and it's just for enrolling, just for those services. But we have decided to go a step further and to make sure that we do the legwork and find providers who accept Medicaid. We ask for feedback on the care that people receive so that we can make appropriate referrals to other people, and also so that we can leverage better health care in the future. So we're preparing for that time. It appears as though there will be more funding for providing support for doing that work. So supporting people in finding medical homes, and then providing that feedback mechanism so that the lead agency can actually kind of, we're hoping what they will do is provide sort of a hammer for medical providers to begin to provide appropriate care for homeless and low income and injectors. So we're hoping that that will be a point of leverage. So next slide, please. Okay, so our outcomes. Since October 1st, TNEP has enrolled 40 people, mostly with Medicaid, and we're focusing on people who would not otherwise have access to enrollment. Our 14-month goal is to enroll a total of 630 people. We have already developed extensive research on local providers who accept Medicaid, and also providing services like transportation. So you can have health insurance and you can have an appropriate provider, but if you can't get across town, you know, it doesn't really matter. And the transportation locally is really tough. So those are sort of support services that we're putting into place. We have deeper collaborative connections with other CBOs and governmental agencies. And we've really, I know that we've created exposure for people who wouldn't otherwise know the value of syringe exchange and harm reduction. And we've had the opportunity to mainstream harm reduction concepts into the healthcare reform conversations happening locally. And I know that that wouldn't, you know, it just wouldn't happen otherwise. And finally, we are on the verge of developing an SEP-friendly HIPAA policy, which is, we were so afraid of HIPAA, but we found our way through that, and it will be available. It's not actually put down in writing just yet, but it will be available soon. So if there are people out there who want to see that, let me know, contact me, and I will be glad to get that to you. Next slide, please. Next steps. So we're looking in Washington State for SEPs interested in approaching healthcare and insurance providers for funding. So if you're interested in this, please contact me. For those of you looking at healthcare reform on the horizon in your own states, consider forming networks in advance and look for ways to approach emerging healthcare networks to spell out the value of syringe exchange. The emerging healthcare networks they're looking for ways to reduce healthcare costs, and we fit perfectly. I think Daniel and Cindy and we're all talking about the community health worker model, and so that's a really good model to use in approaching these networks. We want to develop relationships directly with Molina Healthcare, Optum Health, and Group Health, and MultiCare. It's very, very difficult to make cold contacts directly with these entities. It's like, they're like, you know, stone cold fortresses. It's very difficult to get in to make contacts. It's easier to get their attention through healthcare reform meetings, public health meetings, and through networking. Like Daniel said, talk to everybody, and eventually there is access. So next slide, please. So lessons. We've learned to expand the search for funding sources and networking opportunities to include state and federal agencies. And here again, I feel like I'm repeating a lot of what Daniel said, but I've learned that it takes building personal capacity to be able to communicate effectively with healthcare entities and to use their language. It's a learning curve, but it's something that you just have to dive into. You can't wait until you know. You have to just wade into it. Seek input from members of the network and allow yourself to be led organically. So for us, it was like a trail of breadcrumbs. And one of my most recent leads is a local effort to increase what they're calling medical literacy. And so it's another place where we can be of value to folks who are trying to do that with vulnerable populations. Go to public information sessions and look for ways to translate harm reduction into the conversation. And you can have influence in those. I was telling Cindy before the seminar started that it feels like the Wild West out here, and I think everybody on the call said that it feels like the Wild West everywhere. But what it means is that we can have influence as the healthcare structures and processes are being built. We can find places where we fit in and translate the immense value of syringe exchange and harm reduction into healthcare reform language. So thank you very much.
Thank you so much, Alisa. That was a phenomenal presentation. I'm so struck by the way you really demonstrate the importance of being at the table. And the old adage is that if you're not at the table, you're on the menu. I think you're really demonstrating how important it is to be at the table, so you can be at those discussions that you probably never would have predicted would have happened. And you're really doing so much to certainly bring syringe exchange out of the shadows and make it a real player in the social services and obviously the healthcare landscape of your community. So congratulations on that. It's really phenomenal.
Thank you. And if I could.
Go ahead.
Oh, I just wanted to say thank you, and anybody who is having to overcome their fear, like Daniel said, it's not common, common to me either. But you just have to get outside of your comfort zone and do these things and learn as you go.
That is an excellent point. Okay, we are going to turn things over to Cindy Clay from DC.